it actually might be worth saying, because the year was 1993, that'd be 30 years ago. And I had a meeting with a guy named Bill Geckler. And Bill was a nuclear chemist, and he happened to hold the patent on samarium-153 ADTMP. And I was at the NCI, and I was looking around for trying to do something innovative in prostate cancer. Most of our innovation was not going particularly well unless you like Sermon. But anyway, Bill and I started to talk, and I did get interested in the radiopharmaceuticals 30 years ago. And yes, Mayo Clinic on Monday. So here's our theranostics that I had before, and we see it and we treat it, and I happen to love it. So I think it's a great way to approach cancer. It's molecularly targeted radiation. I think we have radiation folks in the room, and you can appreciate what radiation can do to a cancer cell, but you really have to deliver it to the right spot at the right time. And it turns out that if I were a neuroendocrine guy, I could spend a lot of time talking about somatostatin receptor 2, and it is proven to have success. And it turns out that there are other interesting targets that we could talk about when it comes to the targeted radiopharmaceuticals. And there are a whole number of targeted therapies that are potentially going to be moving forward and applicable. But today we're going to talk about PSMA predominantly. And PSMA is a transmembrane protein. We all know about PSMA PET today. The interesting thing about PSMA is that it has a binding cleft in the exterior domain that is allowed specific binding of a number of ligands. And to those ligands, you can attach a wide variety of compounds. As Marty Pomper says, you can put a garbage trunk and get the garbage truck to bind to the PSMA. And it turns out that PSMA is not specific for the prostate. It's predominantly expressed in the prostate, but there are other areas where PSMA expression occurs, and this can include the proximal tubules of the kidney. It can include the small intestine and the brain, by the way, and a few other sites. So it's not perfect, but it's going to be good enough. Now, when it comes to molecularly targeted isotopic therapies, we're moving fast for these small molecules. But if we sit back for a minute and look at the broad field, it's not just about these small chemical entities. There are also peptides, antibodies, minibodies, aptamers, naked radionuclides. Radium is naked. Iodine is naked. We've been using iodine in thyroid cancer for forever, since the 1940s. So we're a little bit focused tightly, but come back in 5 years, and I think the focus is going to be a little bit different. So the ligands that we're using today are predominantly PSMA 617 and PSMA INT for the treatment. And each of these have a chelator. It turns out to be DOTA. And DOTA can bind a bunch of metals and bind them pretty tightly. And so you've got a PSMA, trying to get that arrow going. This is the PSMA binding motif right here. And here's your DOTA right here. And you can stick on a variety of things. Well, what we've been sticking in there predominantly has been lutetium-177. But there are a lot of other things we could stick on there, like actinium-225, for instance. PSMA INT is also in development. This is 0.2002. PSMA 617, when you put in the lutetium, is going to be called Pluvicto. Now, isotopes. This is getting to a small degree to the point that was raised a little bit earlier in the discussion. It's like, what about all those other isotopes? Well, there are a bunch of other isotopes that are out there. One that is getting a lot of attention right now is terbium-161, and it's got both conversion electrons and Augers. The interesting thing about these betas is the lower energy betas are actually probably the ones you want. You don't want a real high energy beta like yttrium, because you end up radiating too much. So something like lutetium is only going to radiate about 0.3 millimeters on average penetration. So it's really, really targeted radiation therapy, which I think is super important. And there are other ones down here like copper-67 that is getting a play. There's some rhenium-186 and 188 that are proceeding forward. So there's a lot of different isotopes that are being looked at. These are just beta emitters. I'm not even talking about the alpha emitters. Now, I think it's important to understand a little bit of history because, these did not emerge overnight. The actual data that I think is relevant goes back to 2013, 2014. On the top here was actually the first report of PSMA targeted therapy, and it actually used I-131 as the isotope. This is a guy by the name of John Babbage, or Haberkorn is from Heidelberg. John Babbage is now splitting his time between New York and Boston, but these guys really came up with the first PSMA targeted therapy. And then Richard Baum was the first one to really start using the lutetium. So that's kind of where it came from. And the first time it kind of came to broad attention was in a multi-institutional study from Germany. And here you're looking at why it's almost like a registry. Everybody put their data together from a variety of German centers. And these German centers unequivocally showed that there was activity, but there was no optimal dose. There was no optimal schedule. There was a huge amount of heterogeneity with regard to how the treatment was taking place. Now, I can skip forward, and I will. I'm not going to talk about the Australian contribution, but it was important because they did the first prospective phase 2, and they established a dose at 7.4 gigabecquerels Q6 weeks that we adopted for the VISION trial. So I kind of left off the Australians, but that's simply because I'm trying to cover a lot in a brief period of time. So this is the article I showed before. Now I want to go into a little bit more detail. Everybody had progressive metastatic CRPC. Everybody who enrolled into the trial and was treated had a positive PSMA PET scan using gallium-68 PSMA-11. A lot of people have asked, well, what about the DCF-PYL F18? I personally don't think it makes any difference, but the trial was done with PSMA-11 gallium-68. Everybody had to have had a taxane pretreatment. Everybody had to have had an abiraterone or enzalutamide pretreatment. And in that case, there was very little apalutamide or darolutamide in use, so it was basically Abunine. So everybody had to have an ECOG performance status of 0 to 2. The randomization was going to be 2-to-1 to lutetium plus standard of care, or standard of care alone. Standard of care was a protocol-permitted standard of care. We didn't have any data showing safety with chemotherapy, so we excluded chemotherapy. So the physicians could choose pretty much whatever they wanted to choose, and they could use external beam, they could use a novel hormone, they could not use experimental therapies. We did not want 2 protocols ongoing at once. But it was a standard of care plus or minus lutetium with 2 endpoints, rPFS and OS, and a variety of secondary endpoints and stratification factors. Now, one of the things that was really important was the selection of patients using PSMA PET. And we had 1,003 patients that actually got the PET scan as part of the protocol, and 869 or 87% met the PSMA PET criteria. So it turns out this was higher than expected. We went into the trial, we were thinking this might be 75, 80, it turned out to be 87. So what were the pre-specified criteria for PSMA PET positivity? Number one is it just had to have an uptake greater than liver within a metastatic lesion. So that was really easy. It just had to be metastatic lesion, PSMA PET uptake greater than the liver. Now, no size criteria. I mean, if it were 1 millimeter, if it were 8 millimeters, if it were 20 centimeters, it would all qualify. So we're very, very lenient in that regard. We also wanted to exclude, without doing FTG PET, by the way, the PSMA negative lesions. So everybody had cross-sectional imaging. Everybody had bone scan and CAT scan. If there was a metastasis seen on in the CT scan, and say in the liver, and it was PSMA PET negative, meaning uptake less than liver, that patient was excluded. We also looked at lytic bone lesions. If they're greater than a centimeter, PSMA PET negative, we excluded them. If they had lymph nodes that were greater than 2.5 centimeters, PSMA PET negative, we excluded them. We made this up. This was totally arbitrary, sitting around trying to figure out how to do it going forward. By the way, we modeled it a lot on the Al-Simca trial, which used a series of inclusion-exclusion criteria, excluding visceral disease, et cetera. Nevertheless, UCLA ran a experiment post hoc looking at those people that are PSMA PET negative according to this criteria, and their prognosis was really bad if treated with PSMA PET targeted therapy or PSMA targeted therapy. So we actually chose correctly, but it was a thought experiment. We didn't have data when we let off. These patients were very heavily pretreated. Not only had they had one hormonal regimen, which was true in a little more than 50%, but it turns out that anywhere from 38 to 45% of patients actually had two hormones. So they gone through Abi and Enza. And for taxanes, everybody gone through one taxane, but over 40% of the patients had had two taxanes, and over 40% of the patients had had cabazitaxel. So if you looked at it, this was not third-line therapy. A lot of these patients were really fifth-line. They were post-Abi, post-Enza, post-docetaxel, post-cabazitaxel. These were very, very heavily pretreated patients. And I showed you the primary endpoint before, the overall survival, hazard ratio 0.62, good confidence intervals, hazard ratio 0.4 on the RPFS. And there's a little bit of a story here that I'm skipping over because the trial had to be resized. And I'll tell the story briefly that it turned out that nuclear medicine sites that were not well cooperating with the oncology sites were not following the control group adequately. The control group dropout was more than 50%. So when we figured out that 50% dropout was ongoing and your trial depends on the control group, you can't just follow the experimental group, you got to follow the control group too. Sites had to be shut down and hard feelings occurred. But it had to be done. It absolutely had to be done. So here's the PSA waterfall plot. Confirmed decrease in PSA. By the way, it's a little bit different than the Australian trials. The Australian trials show best response to PSA. We showed the confirmed response, and it's about 46%, much better than the control group at 4.1. One of the things that was interesting, and this was a little bit of a surprise to me, we were quantitating the SUV uptakes on the PSMA PET, and there was a good relationship between SUV mean and RPFS, but for the OS, everybody was the same except the highest quartile. The highest quartile PSMA PET uptake lived the longest following the treatment with the PSMA lutetium, but the bottom three quartiles all went together. So it's not, there seems to be almost a little bit of a threshold effect. By the way, all of these were better than control group, so PSMA lutetium was better than the control group in every instance. Now, this was also interesting to me. You know, I had kind of gotten in my mind that PSA is a great marker early on and becomes a less good marker as time persists. So in this post-Abi, post-Enza, post-docetaxel, cabazitaxel space, I did not think that PSA would perform very well, but I was wrong. So here's the data presented at ESMO last year for PSA decline, and this is predominantly a 12-week endpoint. Remember, the cycles are every 6 weeks. And these are the patients who had a PSA decline of greater than 90%. These are the patients who had no documented PSA decline. This is somewhere between 0 and 50, and this is 50 to 90. The bottom line is, at 12 weeks, based on your PSA, you fell into very different categories. And these individuals had median survivals of only about 8 months. And these individuals who dropped their PSA by 90% or more never even reached the median survival. So PSA does matter. And that raises a really interesting question is, what happens if you're progressing after 2 cycles? What should you do? Well, a lot of these patients don't have very good options, so that becomes a different story. Adverse events, I know this is small. What I think is relevant is fatigue. Fatigue can occur more prevalently in the lutetium-treated patients. Dry mouth, unequivocally so. It's not typically severe, but dry mouth is a side effect. If you're looking at a PSMA PET scan, you look at those parotids light up. Well, guess what? You're also going to be radiating with PSMA 617 lutetium. You're going to be radiating the parotids as well. You're going to have an excess of nausea. Some patients do get nauseated, and some patients do have some anemia. The rest of it is kind of sprinkled around. There were occasional vomiting, more common in the control group, but most of it's not much. Thrombocytopenia, not much. So what do we know from VISION? We know now that the lutetium-177, PSMA 617, is effective and well tolerated in these very heavily pretreated patients. We also figured out that nuclear medicine sites that were not well partnered with oncology had difficulty managing the control group. And you really have to do multi-D care. So if you're putting together a trial in this space, you've got to have multi-D. These patients are too sick to be managed by people who are not familiar with managing them. There are a lot of things we don't know from VISION. For instance, we don't really know what the optimal selection criteria is. Maybe we should have had different PSMA PET criteria. Maybe we should have used FDG PET in addition to PSMA, and the Australians do that. We don't really know the optimal dose and schedule for the therapy. We latched on to 7.4 gigabecquerels given every 6 weeks for up to 6 doses. We don't know if that's optimized or not. We know nothing about retreatment from this trial. There are other trials that retreatment can be effective in some patients. We don't know a lot about the standard of care. Is standard of care important? We don't know about the pre-chemotherapy space yet, but we will. And we don't know about therapies that might be synergistically combined. So there are 3 trials that are metastatic CRPC. Each of these are in the post-Avienza space, but pre-chemo space. One is called the PSMA-4, another is SPLASH, and one is ECLIPSE. This is using the lutetium-177 PSMA-617. This uses INT, this uses INT, both with lutetium. PSMA-4 on December the 5th of 2022 is announced positive, top line positive. We've yet to see the results yet. SPLASH has completed accrual. This is one from Point Biopharma. Completed accrual, no results yet. ECLIPSE is still accruing. So all of these trials are moving into the pre-chemo space, and that's important. Now, briefly, I'm going to divulge or move into alpha particles. So betas are like little electrons, and they fly around the speed of light, moving really fast, and they cause single-strand breaks as a whole. Alpha particles are big particles. Everybody's familiar with proton beam radiation. Well, this is like 2 proton, 2 neutron radiation. It's big particles, very destructive in short range. They only go 50 to 100 microns, so incredibly targeted, and they cause a lot of double-strand breaks. So they're highly lethal when they hit a cell. Now, everybody knows about radium, and that's 2013. That's almost 10 years ago, okay? That was the first alpha emitter in medicine. I'll say hats off to Roy Larson and Oyvind Brulin, because Roy and Oyvind were really the ones who developed the patents and put Algeta together, and that was subsequently bought by Bayer. But the bottom line is that radium only goes to bone stroma. And I think if we're going to take the next step, we're going to have to use tumor-targeted alpha therapy, not just stromal-targeted therapy, and particularly stromal-targeted in bone. So now we're beginning to think about isotopes beyond the betas. Here are the alphas that are in play. The big one, the one that everybody's heard of now, is actinium-225. It actually has 4 alphas and 2 betas. And so it is an what we call an in vivo alpha generator. You inject the actinium, it emits an alpha, and then you got 3 more alphas that are going to follow. And then lead-212 is a single alpha, but actually there's a beta first. And then there's astatine-211, which has 1 alpha. And these are the 3 that are in play right now. So astatine-211, lead-212, and actinium-225. Now, I'm just going to show, these are like vignettes, okay? I'm going to call these catalytic images and selected data. So this is the one that got me motivated to think about actinium. So this is a guy being treated out of Heidelberg, and he had already gone through, as you can see on the left, Lupron, zoledronic acid, docetaxel, carmustine, abiraterone, enzalutamide, radium, abiraterone, and estramustine. His PSA is 2,923. This is his PSMA PET scan. And he gets 3 doses of actinium. His PSA drops to 0.25. His scan goes to that. He gets 1 more dose of actinium. His PSA goes to less than 0.1. So 9th line of therapy with actinium-225 targeted. This is, by the way, PSMA 617. And I said, oh my God, what are they doing over there? I got on a plane, I flew to Heidelberg. I said, guys, what are you doing? Okay, this is nuts. And it turns out that there are a variety of interesting things about the alphas. So the PSMA actinium-225 can overcome resistance to PSMA lutetium. So here's a guy right here who gets started on lutetium, gets a couple of cycles. His PSA goes from 286 to 306. I've already shown you that after 2 cycles, your prognosis is very poor if you're getting PSMA lutetium and your PSA is going up. Then he starts getting treated with the actinium-225 and goes into, in essence, complete remission. So the alpha reversal of beta resistance is really important. Now, this is coming out of Mike Sethke at University of Pretoria. Mike is a really interesting guy operating out of Pretoria, working in combination with the German Nuclear Medicine Group. And Mike has more flexibility than the rest of us. And this is his PSA waterfall plot of using PSMA 617 actinium. They don't have a lot of Abienza in South Africa because they just can't afford it. So these patients have an ADT docetaxel, but I think only 1 or 2% or 2 cases have been treated with that, with either abiraterone or enzalutamide. And this is his waterfall plot that you're seeing with PSMA actinium. I mean, that waterfall plot is as good as you're going to see anywhere on the planet in castrate-resistant disease. In fact, that's probably the best one. So this is the one that kind of got me interested even a bit more. Mike has guys that don't want hormones at all. You know, not everybody wants hormones. In South Africa, they refuse hormones. Mike says, okay, I'll treat you with actinium-225. So this is metastatic hormone-sensitive prostate cancer, no hormonal therapy, just being treated with actinium, and that's the waterfall plot you get. So that's pretty spectacular. It kind of looks like hormonal therapy. We don't know a lot about the duration, obviously a small trial, but this sort of triggers your mind to think about things in a different way. Many of you are radiation docs and you understand radiation. And we also understand the heterogeneity of disease. The thing that is so powerful to me is that if you get the right radiation to the right spot, that you can have a tremendous effect on the patients. And I'll tell you, I'm putting a considerable amount of my own efforts now into not only the betas, but also the alphas and trying to move them forward because I think radiation can kill them all. Thank you very much.